Um, I won't stand between you and your refreshments. At 5 o'clock, I'll make sure we end, because it's a very dangerous position to be in. So, my session today at this time is answering questions that have been raised since this morning. Every patient advocate and patient organization has been asking me one single question: how do I change the healthcare system in my country? How do I then work with the policy elite? How do I influence things? How do I participate and learn from others? And I hope this helps us to put those questions into reality. There's a route available for you to work with the WHO, the World Health Organization, and with the WHO's regional committees, which are WHO Southeast Asia Regional Committee and the WHO Western Pacific Regional Committees. I will start off by looking at what this means to you, why becoming a non-state actor accredited by the WHO SEARO and WHO Asia Pacific will work, and what we need to do to make this happen. We started this morning by starting from the first things that we do need a predictive, preventative, participatory, personalized, and preemptive healthcare in our region. If we believe in these five, then it is very important for us to talk to our governments individually, but also to have intergovernment influence. Make sure we are, as citizens of the region, have that cross-border dialogue, because that works effectively. Health may be a political choice, health may be a sovereign matter, but we as patients, we know we don't respect any of these borders. We work with each other wherever we can, and we work collectively. To us, one sick person is just like you and me, and we show patient solidarity. Patient solidarity is what's driving this for us. In WHO, SEARO, and WHO WPRO, we have healthcare systems, the institutional legal frameworks, policy, practice, and standards not widely known. We saw here today, it's like walking around the elephant blind, you know. Each of us is thinking differently about what she should be. But when you sit together in an alliance, national alliance like this, you start looking at things, discussing, and when you talk, you understand. In Africa, Alice knows about this very well. We always say that by talking, you define the devil or the spirit, and by defining it, you're controlling it much better. We need to know what this healthcare framework is, and more importantly, how can we shape this framework for us, our need. So that's a premise that we need to change. We're not talking theoretical. Somebody, if your minister or somebody says to you, what right have you got to speak to us on health matters? Health is sovereign, or you shouldn't talk about health. It's not your promise. It's not for you to do. You take your medicine, go home, sleep it off kind of thing. We must remind the minister that the member state, the country has ratified the WHO's constitution, and the WHO's constitution gives us those rights to ask questions. That's where we're getting our rights from. That health is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. So mental health comes into it. Welcome comes in. And the enjoyment of the highest level of standard of healthcare is fundamental right. So now we are changing the language. We have to change our language when we speak. We must speak of rights, rights-based. And that's something we must use consistently, rights-based approaches. And when you know a right is something that you inherit, you don't beg for it. It's not a privilege for others to give to you. This is something you're born with. This is where you come as your birthright. And therefore, when you ask for this right to be exercised, you're not begging. You're just asking for the state to protect, fulfill, and respect that right. Nothing more. We are not imposing anything else. And clearly, WHO says, and this is where we take the other power working in the region, that people's health and attainment of this right is dependent on the fullest cooperation of individuals and states. This is why we are working with each other. This is why Bhutan Cancer Society is here with Thailand Cancer Society. That's why we are talking to each other. Korean Cancer Society is working with us. Cirrhosis Philippines working with Cirrhosis UK. We must work together, and this is what we are doing. Now, this is from the European Union. And I always come with this model from your party and the European Union because in Europe, what is called the social contract between the state and the individual has over years of expansion. It goes back in history with some of the earlier thinkers on this, that the state and the citizen has got much more deeper involvement. Similarly, we have a new contract now with industry. You see our industry partners here who are recognizing that the patient involvement in medicines R&D is much more than just being a subject matter. We are not here to be done things, poked and given this and used as partners or part of either a control group or the active group. We're here to set up the research priorities. That's our duty. Our duty is to help in the research design and planning. Our role is to help in the conduct of the research and operations, and most importantly, our role is to disseminate these results post-approval so that we don't have the situation that happened during COVID in Europe, unfortunately, of all places, where AstraZeneca got an approval, but one of the governments decided, no, it's not going to respect the European Medicines Agency's approval. And then everything fell apart thereafter when anti-vaxxers got in, and we had a lot of, what do you call it, infodemics step in, and total chaos. Let's follow the U-Party model and make sure we are part of parcel of this. We are contributors, creators, and co-producers of innovation. And the state must respect this. State must give us a platform. It should give us the policy framework for you to do so. It shouldn't prohibit the industry from talking to you and finding your ideas. It shouldn't prohibit us from joining. So we must make sure that these are open pathways. We can all touch them. We need new agilities, new frameworks, and new connections. The WHO has got a document called the Framework Engagement for Non-State Actors, FENSA. FENSA was approved at the 69th session in 2016 of the World Health Assembly. This is a framework of engagement with non-state actors, and it defines how WHO can start working with you. Ideally, and this is I make clear, in international law, when the state signed the WHO's constitution, it was an interstate matter. It was a matter between WHO as an agency of the United Nations working with governments alone. And therefore, it could not jump that. There was a gatekeeper that was a member state. This FENSA allows the WHO to talk to people behind that stage, so we can talk to those on the ground, non-state actors who are actively engaged in this. And therefore, it gives us a very good way of completing the cycle. It's very good from a point of democratic interest as well, that in line with FENSA, non-state actors are really private entities, non-government organizations, patients organizations, private sector, and academic institutions. So now you can see here what a National Alliance of Patients may look like. We could have in Thailand, Prince Maidul University as academic partner. Then we could have the King's or Prince Royal Foundation as one of philanthropic. Then you might have industry or private sector partners, including digital health as partners. And then non-governmental organizations like yourself and others. We are uniquely placed. I think this is something we must recognize, and that we should be proud of. That we are uniquely placed to represent and reach the target population. After all, the WHO is about patients, the government is about patients, and we are the intermediaries in that. We are like the oracles, we speak to the patients. So therefore, let's use that, let's build on that. Let's get that information streamlined. We are the people who improve the connections. We are the joiners of, we are connecting people with the state and the WHO and the policymakers. We are the gateway for that. And we must advance those objectives of the state and WHO. So therefore we must, as I said, it's our, not only our responsibility, it's our duty now to do that, to help this. During the pandemic, you saw there was only one organization in the world representing us all, and that was the WHO. We knew that without WHO, this pandemic would not have been controlled as fast as it did. You had national governments trying all sorts of moves to resist that, but WHO, and I'm thankful for Dr. Tedros for having pursued this relentlessly, making sure we all work together in controlling this and not in isolation. There are two ways to engage with WHO. The first pathway, which IAPO has adopted, is a non-state actor in official relations with WHO. This is open for organizations that work internationally, have a global presence like the Cirrhosis International, UICC, you've got the International Diabetes Federation, International Cancer Associations, etc. And including the International Federation of Pharmaceutical Manufacturers Associations, it's a non-state actor in official relations, and the International Federation of Pharmacies, FIP. It's a privilege. We must remember this is a privilege. It's not a right. It's like your driving license. It's your privilege to drive. You must respect it, and you must not abuse it. You must not undermine it. You must not do anything untoward to bring it to disrepute. And currently there are 216 non-state actors in official relations with the WHO. And we all get a right to appear in Geneva at the World Health Assembly and join in any of the other events. So I would like to see that extended to regional committees levels as well. Africa, strangely, is leading on this now. Alois Lodzenieva, Vice Chair, is here today, and he can talk about this. That the WHO Africa office, regional office, has opened up the door. They're using this option in the FENSA that for non-qualifying members who can't qualify as in official relations, they can, due to their limited geographical address, they could become, they provide the regional, FENSA provides the regional committee like WHO SEARO and WHO WPRO that they may decide, they may, see this is still, we've got to work on this really hard. This is where our advocacy, We have to influence this. They may decide of granting accreditation to their sessions. What this means is that we could be at their sessions and talk directly to the ministers. One body of patients accredited could sit there and really influence change. It's a direct pipeline into that. A minister who didn't have time for you because they were busy during the year, during regional committee level, he or she is accessible. They're sitting at arm's length from you. You're given 3 minutes to make an intervention on the floor, and you can say what you have to say, diplomatically and with respect, but forcefully on the issue. Now, African patients have got this route opened up for them. We're just waiting to see who are the first qualifiers, and we will see from their experience what is happening. And Africa is leading on many aspects of the African Medicines Agency as well. This African new route is proposed that those who are not in official relations obviously get involved. And accredited non-state actors can participate in the regional committee in Africa. And upon invitation in sessions of the regional committee, and to submit written and oral statements, yeah? You can put that oral statement, we cancer patients, we need this in the region or nation. We people from diabetes need this, and so forth. The accreditation procedure is quite simple. And this is where IAPO will step in and work with you, all bodies, make sure we are synchronized. The first is that your organization's memorandum and article of associations must be consistent with the WHO Constitution and in conformity with the policies of that organization. We're working with the Advocate for International Development, A4ID. Please have a look at their website. I'm trying to get them to help us. They've helped us a lot in the past. A4ID will help us in drafting some of the model constitutions that your boards and chairs may adopt as amendments into your constitution, or you can borrow it entirely and place it as a section in that. The organization must be actively involved in the region of Africa, and this is why we're bringing you in. We make sure you're recorded. Please use your Twitter accounts, your Facebook, everything, because that's the evidence we will collect after this. Please tweet, please send things so that we can then collate that. You can show that you're actively engaged. You were here, you're talking of these things, you're part and parcel. You're not just a shadow organization. As I often say, some of our patient groups are really only groups and by word on paper, very often led by entitled narcissists, you know. We hear more about them and less about themselves, of the group or work they're doing. Don't talk about yourself, talk about the work you're doing. That's what WHO wants to know. I know many of you, when they put co-founder or founder, have serial founders. One person I found he has founded 8 organizations in the past. Now, but yet I don't find him ever active in any of these real policymaker changes. So what are you founding for, you know? Please, found and enact. Well, stick with one, you know. You don't jump from partner to partner. Be monogamous in this issue. Be loyal to the organization you create and help it. And then, again, as I said, the regional should be there. Non-profit in nature, and this is, we are getting this non-profit really hard. We are pushing this. I know limited liability companies being set up by some individuals and in the mistaken belief they become a non-state actor, but not in this case. It's okay with the WHO in official relationship. You have to go through a FENSA thing, but not at a regional level. I must have a constructed, established structure, consecutive acting accountability mechanism. Here we can put those policies for you. The standard policies that you want to have in a system, let's create those and borrow and adopt those. Good governance, that's what we have said here. It's innovation and good governance. Very important for us. It's part in that theme. Without good governance, we will have challenges. The accreditation procedure, what do you need? You need a name. Please make sure, as they saying in English, there's an advert by Ron Seal, manufacturers of a lacquer for furniture, which says, Arrow says it does exactly what it says on the tin. So make sure your name is exactly what it says on the tin. So I can immediately know who you are from what you're doing. I've got people who have named things out of split name. The woman has used her surname and attached it to her husband's name, and this is of organization. I'm sorry, this is not a family trust we are looking at. We want to say what you actually exactly do. So again, our narcissistic, entitled individuals who have, make sure the name is clear. Then the objectives, make sure your objectives are clearly set. And this is why we are asking for synchronizing them with WHO's objectives. To a larger degree, we can adopt. Yes, there'll be some uniqueness. You may have certain areas you may be concerned about. Insulin and diabetics will be different from cancer. But let's make sure we have at least got the WHO's missions and vision in there. Have a good governance structure. This is where Nidhi Sarup, who's sitting here, we're talking about the idea of a patient academy for Singapore and the region. And again, Einstein, is he somewhere? Einstein from Philippines was taking the same. And I think this is what we're looking at for you guys to do. The academy should be looking at educating and training on governance structures. That's your work in the region. You know, it shouldn't be global or somebody else coming from outside. It's you. You do it. It's your duty. Make sure the main decision bodies are clearly set out. You know who they are, what they do. Assets, make sure you do have some assets to work at it, because sometimes it means that if you don't have enough cash flow, how are you conducting? But show that paid in crisis. There's one organization, please look at the accounts, yeah? And they see Max Foundation. Max Foundation, they'll be here tomorrow. Look at Max Foundation. Very good system. So they will have about $1 million and a half in official currency, hard cash, but over 6 million in kind access. Have a look at how they've counted that. It's amazing, and that's what we need to show. Put your time and account for it. Put it as an asset. It's something that came from the tobacco industry a long time ago, when they started using their brand as an asset and a value. You value your brand, put it in the assets. Make sure you've got annual income and funding resources, and this is where we can work with you again on funding strategies. Our industry partners here who can be very generous. I know GSK Thailand is here, that really looking forward to help national Thai or patient organizations, how they could help and how could we work it together. Again, your main, let's put us on your affiliations and website address, so we can all then show that we are not just on our own. We're acting in group, that we're working together. And then the summary of engagements with WHO. We'll invite you to all the events we are doing. This is why we always insist on you joining our webinars, etc., so that you can be part and parcel. You can show you are part of that scheme. How is IAPO going to set up supporting people in Africa? And this is where you've got to be looking at that. Let's set up the same program. We will try to help the patient organizations shape their vision, mission, values, and policy frameworks to that required. FRID will help us in that. Again, IAPO will help you through WHO engagement with regional events, especially during the Philippines. As I said, Paul attended those. And for WHO SEARO, we had our JIT turning up at Bhutan. Then in AMRO, we were doing the same. Again, the structure of the Constitution and accountability will have advocates for international development helping us incorporate this framework into it and work towards that. Timing, as I said. For Africa, we were very clear. We start putting in our applications in quite early. That was the deadline for us, was 15th October 2022. And many of the organizations put this in. And hopefully now we're waiting for the results where they come back. And once we get this action undergoing here in the region, hopefully we will get this incorporated. So we need to do a lot of work in this region. Can we do it in SEARO and WPRO? We want to approach the regional committees together. Let us put together a package, advocacy, maybe elect one of an organization here in the region to back it up. And we can prepare this document and ask the regional committees to look at involving us in all their consideration and next regional committees. And make sure we are there in that. Our excuse, and I think this is very important for us, we have a golden opportunity in the Global Patient Safety Action Plan. Please access this document and you find in there WHO, SEARO and WPRO, and each government has been asked to engage patient organizations and families in this action plan. They've been asked to develop capacities in you. They've asked to map you, register you, fund you, do this, do that, and then to take your insight, make sure you're present everywhere. And one of the targets, one for 4.1, is it will be asked the governments to have at least 60% of your hospitals to have a patient's organization or something similar in place in the decision-making body. Make sure you're present there. That means all your infrastructure must have one patient decision maker, part and parcel of your health decision makers. Let's use that. Let's tell them, yes, here's your move. What are you going to do? You know, this is one of the ways I call it silent pursuit, nudge. Just ask them, dear Minister, what are you going to report at the World Health Assembly to the Director General of WHO on patient engagement in your Global Patient Safety Action Plan or National Safety Action Plan? What are you going to report? The answer, he can't report nothing. He has to have it there. He can't say zero. And that will alert him, oh, hang on a minute, or her. Oh, by the way, Undersecretary, Ministry, what are we doing, you know? I'm not going to turn up at the thing and look embarrassing, you know. If the Philippines has got 20 patient organizations already there, Thailand has almost 70%, what will I look like, you know? And I don't want to be embarrassed. So please do have that, use that Global Patient Safety Action Plan as your route. Take that document in your hand and shake it. It says, here is what you should be doing. And tomorrow I'll be undertaking, I'll walk you through that whole Global Patient Safety Action Plan, how to turn it national. Why do you want to be there? We want to make sure, tell the government, look, we are trying to help you to achieve harm-free healthcare for all. And I've said this case in Honorable Jeremy Hunt when he was not the treasurer as is today. When he was health secretary, he used to narrate this story. He said that whenever patient harm happens, there are 3 casualties. Yeah? The first casualty is the patient themselves. The second casualty is the patient's team. You know, it can be devastating, especially if it's a junior doctor. Careers can be ended. They feel for you, you know. So nobody wants to harm or kill a patient. They're there for caring. That's why they're there. And the third casualty, again, because health is a political choice in universal health coverage in NHS, the third casualty is the government, you know, like big scandals of blood contamination that we had, child side. So they don't want this to happen. So let us help the government be stable, you know. Let there not be patient harm, you know. People always criticize you. Health is very important to all. And in the United Kingdom, when the universal health coverage was first set up, the NHS, there was a very strong minister called Henry Bevan who said, I am setting up this healthcare in such a way that if a bedpan, you know, bedpan is when people are incontinent or that, or can't address their physical needs. The nurses provide a bedpan. If a bedpan falls in a hospital ward, in, for instance, remote part of your health system, its noise should be heard in the Westminster, meaning that that incident should be heard or be by the government of the day. So if any patient harm is happening, we should know about it. This should be. That's how we want this system to be. If it's people's system, that's how we should be connected. Now we know the Global Patient Safety Action Plan has clearly said it, that without us, there's nothing. So therefore, nothing about us without is what we're trying to say on this action plan. We need to be there. We need to be at the table. Now, I've given you a small snippet. I'll just run through it quickly, but in WHO's Global Patient Safety Action Plan 4.1 of family engagement says that you have to do this. You have to ensure involvement of patients, families, advocates, and champions. Nothing can be clearer than this. Your minister has to do it. There's no other way. They have to do it. Next, you step in. I was telling the GSK, crowd on pharmacovigilance, that we must help them develop this frameworks for principles of engagement and implementation tools for patient and family engagement. We can tell them how to set it up. What is it they're doing? How should we be doing this? We should provide advocacy to member states. We must be individually telling member states what to do, establish the policy tools needed for patient engagement and guidance. We must involve patients in patient safety networks. So this is why I said a national Thai patient safety action network would be the best thing with Duke NUS or with our friends from Prince Maidul on it. And the last one in this, we start speaking the language of rights-based approaches. We need a national model patient safety rights charter so that you can go and access it and show your rights have been legally bolstered, that you're not given word, they say, without that piece of paper, that it must be there. You must have that right defined. It's important for democracy. It's important for society. 4.2, this is what we are here for. It's important that everybody learns from our experience. I cannot see how Apple could exist without learning from Apple users. All the innovation they're bringing in is through Apple users. Nowadays they're using AI. They're learning from how you're utilizing, how you're acting with the device and with the system and Apple. They're learning from that. We must provide this insight. We have a right to share it. I don't want us to be standing in forums and, shouting to people, anyone who will hear you, it's standing in the corner. That is not good for us. Let's talk sensibly, reasonably, with great import and seriousness to the right people in the right places, on the right topic at the right time, and with the right push. We must engage in research. For instance, now, how many of your members have had a pharmacovigilance incident? Find out. Let's share that. Let's work with industry. Let's work with the government. Let's work with the academics. Let's create those things. On social media, things are so fast nowadays, we can be together with people in no time at all. You can pick up things happening in Finland with going on that could be relevant to you. Make sure you collect these global stories. It's very important. Global collections are very important at patients. We must feed into it. We learn from stories. We learn from what not to do. As children, we began that way. We are told great fables, the wolf and the Red Riding Hood. We have got stories of the snake and the apple. We have this and that. But that's what we learn from. Let's talk about those. Make sure that our experience, and more importantly, like myself, I always talk about the positive outcomes for me. That my health system was very good in dealing with me. Let's talk about the positive as well, not only the negative. If I spend 4 hours in this morning, like I said, I just touched on the subject that early diagnosis was possible, but I spent more time the whole day talking more about the positive way it dealt with me, how they came to serve my need. 4.3, it's you. My friends, my partners, my colleagues, my patients, you are here. You are the messengers that we need to engage and take. You're the champions. We want you to go and strengthen the WHO Patients for Patient Safety program. Join them. I know Nidhi will tell you, follow her because you'll be hounded during drinks. She's gone on to become a new patient safety champion registrar from Singapore. Share those websites. Neelam Dhingra, who is in charge of the program at WHO, will be really pleased. We're promoting it. We must provide the advocacy and guidance to support the establishment of patient for patient safety programs in countries. Your WHO regional and national bodies can help you. Let's develop those educational and technical resources, and I'm glad Nidhi and Einstein talk about that patient academy that you're looking at. We can't do regionally. You have to do it nationally first. Your health system is very particular. This thing is very particular to you. The legal framework is different. Your policies are different. So we can't give generic, bland vanilla flavored program. You have to give the specific taste. We are here as IAPO to help build that capacity of patient safety advocates. And then be the grease and the oil between civil society, other organizations, like we're trying to work tomorrow, LGBTQ, Dr. Asya Sheikh will be here. Hopefully, Asya Sheikh will talk about LGBT. With Bangkok, again, having such a liberal attitude and being the capital of some of the surgical operational when you have gender reassignment around the world, very, very sensitive. It's a mecca in a way to change. And therefore, let's use that Bangkok as that LGBT example. Let's build those relationships, let's bring those groups in. 4.4, almost there. So 4.4 is really incident disclosure. As Jeremy Hunt and Sir Liam Donaldson, who had the Global Patient Safety Action, have said that to err is human, but to forgive is divine. Let's deal with no blame game here. Let's not blame people. Let's use that, learn from that lesson. Let's open up. Let's have a learning culture. Let's make sure we go to the root cause. And Jeremy Hunt was very good in this. He was bringing in the no blame culture, trying to introduce compensation schemes that were easy to follow, easy to bring in. And that requires patients giving way to this, you know. So in future, I don't want patients running to the lawyers. You go to the lawyer, you're going to lose 60% of your compensation with further damage to you over the year. One time, even not one time, there's currently health systems in the world which have got more lawyers than doctors working in this area. All your hard-earned tax dollars are going paying the lawyers. And Jeremy Hunt brought this great revolution in this. Overnight of a, what is called legal aid, and of a, at that time it was called the NHS litigation team changed. Now we talk about litigation arbitration, you know, it's called NHS resolution. There's no litigation, it's about sitting down the arbitration, but it's talking to you. Again, let's have transparency. I don't want years later, you know, you find out the doctor's been killing people and then the scandal breaks out. Let's bring out the bodies up front, you know, and we can make sure it doesn't happen. And make sure the government even sometimes suppresses some data, you know, when they know things have gone wrong. Let's put in the guidance and design open disclosure legislation. Make sure it's through legislation and policy. No doctor should hide. No comment, you know. No, come out quickly and let's deal with this. There may be something wrong in the system. It might be wrong with what to practice. Let's find it and correct it. Imagine the next patient is your mother, I always say. Are you, minister, going to tell me that, accept my apologies, sorry I managed to harm your mother because you didn't look at this issue? No, you're going to go for my throat. Let's make sure we find this out before. And last, I think this is why we hold this Asia Pacific Patients Congress. It's about sharing information. It's about education. It's about bringing patients and families to this. And in Bhutan, when I had the WHO SEARO, I was so pleased to see the Bhutan Cancer Society organize a series of events. One of the best was to use archery and kuru, the dart throwing. I think we enjoyed it so much. The patients couldn't believe that you had regional directors of WHO coming and joining us, throwing darts. Ministers from other member states. And the ministers were very competitive. And then our Thai one, I think, was good. There's something about the Thai accuracy, you know, very competitive. They were really good at this. Every morning, I used to find them. I thought I was up and running at 6 a.m. They were up at 5:30, and they were all gathered in the ground doing their sit-ups and waiting to throw their darts. So a very good team. I really like them in that. So let's share that information with the ministers. Let's share with us. Let's enable that sharing. Let's show that patient safety curriculum is included. This is Prince Maidul University. I've spent the last 2 days visiting them. And Duke and US as well, we need to bring them in. bring that into curriculum. And again, for Einstein, work with University of Philippines, Manila. And lastly, to bring the advocate engagement of families as educators. Let's be the educators of things we need to come. Let's talk, let's bring that education. You guys have got immense talent, immense experience. Talk about it and be upfront about it. And with that, thank you very much. We are always here to help you. Please get in touch with us. We will be able to help you on various matters. And I'll take quick questions, and then you got 5 minutes to do it, and be first to get your drinks. Okay. Thank you. Any questions? Good. Action. We can now break for drinks. I will answer when my throat is a little bit more. In a beautiful play by Wole Soyinka, the Nigerian writer, there's an interaction between the village headman, who's very clever, very crafty, and the newly appointed school teacher from the government. And when the village headman goes to visit this school teacher in the official school buildings, the headmaster gets up and shakes hand and says, "Good morning, Bale," the chief. And the chief says, yes, that's okay, but will good morning wet my throat?" It's customary for us to discuss over a bottle of beer. So where is my beer, you know? So let's have the drinks and refreshments, and let's enjoy ourselves and our company. So thank you very much again, and I will hand over to the